Good morning, everyone. How are you? Welcome to the Skills Workshop on Medication Administration via Injection of intramuscular, subcutaneous, and intradermal injections. For those of you that don't know me, I'm Professor Mark, and today what I'd like to do is four items. Number one, we're going to be reviewing the thing that I know you all know very well, and that's the patient safety issues, certainly including the patient right, before we administer any medication. The second that that I will be demonstrating is patient, I apologize, nursing safety measures. We will be doing that during the injection. Three, as we will review the injection sites on the body where we can give all of the medications, different locations, obviously. We'll review those. And lastly, the injections of themselves and a full demonstration of drawing the medication, preparing for the medications, and then obviously injecting. Okay, very well. All right, let's begin by going over the patient safety rights. And like I said, during the demonstration, I will be giving you demonstrations of patient safety during the injections. But let's review. Okay, before we give any medication whatsoever, think about it just for a minute. I know you can't respond to me today of the patient rights for safety. And when we were preparing, obviously we have the right patient, the right medication, the right dosage, the right time, and the right route as our basic five. So indeed, you will be preparing for all of those, right? There are other rights that are there that are important too, and I'm going to mention two more. There are others, but two more important to know, and that is the right reason. And when it comes to some medications, what we will do is the patient right to refuse. This is sometimes being presented to you during vaccine injections, and we'll be talking a little bit about how to handle that. Okay, so we have that. Now, patient safety when I go into the room, eventually, when I go in and prepare to administer the medication, you've got a couple of safety checks here. One is obviously patient full name and date of birth, which we ask them to repeat to us verbally. Then we will be looking beyond that on the wrist to see if they have the red band of any allergies. For sure, those two. Double safety is ask them if they have any known allergies beyond, and then what you would read, for example, penicillin. Ready? So I always ask those questions. Now, real world nursing for what you will be presented with is scanning, obviously, the medications. This is also a double check for things like the right medication, the right time, the right dosage, etc. We will be doing that. Now, what I want to commit to you is that today we will be going through some real world nursing tips and situations that you will be presented with. Okay. Now, one of the issues that I want to talk about is certainly before you administer any medication at all, okay, and we know a little bit about allergies. For example, if the wristband says penicillin to you, and in your hand to inject an intramuscular medication that is an antibiotic, which is new. or as the new nurse, you have never heard of it before, and this may be something that you'll encounter. I'm almost sure of it, with it being new. All right. You don't know if this is compatible. If they have reactions to penicillin on on their wristband, and you know, of course, this is an antibiotic, and you have a new one in your hand, what would you do? Let's think about it for a second. Now, many of you are thinking, oh, and it's not a wrong answer, of course, is that you look for the drug book. Right? Now, real world nursing, sometimes difficult to find. What's happening here? One of the nurse's most precious commodities is time. And you're going to be spending the time searching for the drug book when you get to it. And if you do find it, it may be last year's edition. It may be even previous year's edition once you find the one book, the right book, so to say. All right, I will give you the answer. The quick answer, the most efficient, and perhaps the most accurate, and that is call the pharmacist, right? And ask them if these antibiotics are within the same class, and is there any risk at all for allergic reaction with this new antibiotic? Because once that medication is in under injection status, it's in. And of course, there's no reason to stop the medication from being absorbed. So those are our initial safeties that we want to. Now, when you're in the medication room, preparing the medication, for example, this is any medication whatsoever. We want to check the what? The right medication, of course, the right dose. And of course, in this, we are checking out the correct dosing of the medication. For example, 10 milligrams per 0.5 milliliters. I'll give you an example of heparin, 5,000 units of heparin per milliliter. These are how the medications are dosed. The other patient safety addition that we're going to add here is expiration date, condition of the medication, clarity. Now, even though this particular vial is a milky appearance, I can still visualize that the medication is in there, it's clear, and there's no sediment whatsoever. But critical is that expiration date that's on there. Patient safety, and obviously safety for you as well. Okay, so those are some of our patient safety rights, and additionally, then the nurse will be doing the proper thing, right? Secondly, I promised you nurse safety. We will be going through that in the preparation of the medications, then, and obviously, of course, prior to the administration. Okay, the other item that I promised you was located on the body. Specifically, what we're talking about here, um, first will be intramuscular injection sites. There are three of them, the proper sites for injection of the IM. Number one, can you think of them before I begin? And we not only want the sites on the body by pointing our finger, which I'll have you do at home, but also the right muscle identification. What's our proper anatomical description of the muscle? Number one, perhaps most often used, is the shoulder, right? Specifically, this muscle here, the deltoid injection site. Now, how do we locate where on the deltoid are we going to be giving the medication? The proper identification, which you will get by experience to do visual, is this bony prominence here is the acromion process, right, of the shoulder. I feel that very distinctly, two fingers down, and from that, and then you can see where the injection will be right in the medius part of the deltoid. Today, this little rubber mannequin that I have here will serve as my deltoid because I can't hold it up and demonstrate an injection to you. Right? Secondly, what is it or where is it? On the thigh, right? The muscular anatomical location is the muscle of the vastus lateralis, the largest muscle in the thigh. Today, here's my miniature mannequin of a leg. What we do is anatomically is we line up straight down the middle in the line of the femur, straight down the middle. Okay. Now, we don't inject right on the middle. What we do is to the very meaty part of the vastus lateralis. If you were to divide from the groin area to the knee, you would divide it into thirds, and the injection will be in the middle third. Cast to the outside of the thigh, right there. Right. Once again, femur bone middle, cast about 1/3 of the way around to the outside of the thigh, vastus lateralis. Right. The next one, can you think of it? It's straight on the hip, straight on the hip area, not the gluteus, which would be right on the buttock, on the upper outer quadrant. We do not do that one any longer. I'll tell you why in a second. We inject it, if you can see this, straight on the hip on this side, right? Not back here to the gluteus, the ventral gluteal. Right on the side of the hip. Quick anatomical. The way you do it is I'll hold this anatomical drawing of the pelvis, right, and the greater trochanter. Right? It's between these two, right in where I'm going to point to the obvious site right in here. The way you landmark it is my palm goes on the greater trochanter. My top two fingers, ride upon the top of the iliac crest. Where is the injection? Notice with these two fingers, I'm riding across the iliac crest, and it will be right there, right where the V of your fingers. Now, obviously, you take your hand away, and it is right in this location, as I demonstrated, straight on the side of the hip. So what do we have? Deltoid, vastus lateralis on the thigh, and ventral gluteal straight on the side of the hip. Not the gluteal, as I was talking about, because the sciatic nerve runs right down the gluteus, maximus muscle on the buttock, and we don't want to inject into the sciatic nerve. Lastly, now today, injections of the medication. Notice I'm in the med room right now. I'm going to be prepping the medication. I'm barehanded. When do we put our gloves on? When we go to give the injection and we're touching the patient. First today, what I want to do is a little bit of needle theory and syringe theory. The thumbs go. This away. I'm hoping that you all can see this. We're going to be going through needle theory first. Okay. Now, these needles here, the first one up at the top that we can see here is the red. We're talking about the intramuscular now. The red needle that we're talking first is called the blunt needle. Now, important mark here for the blunt is there's a two-step to drawing up an intramuscular medication from the vial. You use the red blunt for starters. This is how we do one thing and one thing only is draw the medication from the vial. Then in step two, we will convert to our injector needle. The real quick explanation of this and the reason that we do this is to preserve the very sharp tip of the injector needle. Every time we punch the needle through the rubber top on the vial, under the microscope, you could see that it dulls the needle ever so slightly. So what we're going to do here is once again draw our medication with the red blunt. Red, this reminds me, never, never use this to inject with. We do the blunt and once again convert to our injector needle. That's number one for intramuscular. Now, the second thing that I want to go through is needle selection that you will do as the nurse, choosing the needle in this particular case. And when I say choosing the needle, sometimes with insulin syringes and PV syringes, you don't get the choice of needle size. But in the intramuscular, you do. So, what size do we pick? Needle sizes come in two designations. One is the gauge of the needle. In other words, the size of the needle, not the length, but the size, the thickness of the barrel of the needle, the bore of the needle. And you can notice different thicknesses of the needles themselves. Now, that's gauge. Kind of a quirk system that they use is that the higher the gauge number, for example, this one is a 25, this one is a 21, and you notice that it's much thicker. The pink one over at the sides here, let me move that away. If you can see it. One second, I apologize. The pink one is an 18 gauge. So the higher the number, the tinier the needle gets. The second designation is length. The orange one up here is a 5/8 inch. You'll notice as we go down, this becomes about an inch. This particular This one here is about 1.5 inches needle. That's the normal size, or I should say length, of the needle. 1.5 inches is the max that you do. All, by the way, just repeating myself, intramuscular choices. Now, this particular size, I think you know, obviously, that this wouldn't penetrate deeply enough into an intramuscular site. It can be used for number one, subcutaneous injections in the adult because it's so tiny, or intramuscular in only infants. The tiny gauge needle, 25 gauge. It's up there in number, so the needle is tiny. Okay, then as we go down, this is one of my favorite all-purpose needles, 1 inch, 23 gauge, a very useful size of needle. You notice the length, 1 inch, 23 gauge needle for intramuscular. Once again, we want to get deep in the muscle through the subcutaneous fat and the dermis and the epidermis. So we need to have that type of length. Alrighty. So that's a little bit on choosing your needle size, depending on what the nurse needs to do. The next thing I'll go through are the syringes that we've got. Let me get through there. Syringes to choose to go along with the needles. At the top, we have the 1 milliliter. Second down, we have the 3 milliliter. And then lastly, we have the giant 10 milliliter. Most often, as the nurse, you will be using the 1 ml and the 3 ml. How do I choose as the nurse? It depends on your dosage amount, how it's dosed. This is a very good needle. I apologize, syringe. If you use when you have zero point 0.5 ml, right there, I believe. All right, 1 ml divided into tenths of an ml. I don't have a tendency to use this particular syringe when I have to inject a full milliliter. Next, the 3 ml, the 3 ml syringe. This is a good, once again, an all-purpose syringe. It is divided, as you can see, in half an ml, 1 ml, 1.5, 2, 2.5, and 3, etc. 3 ml. Good syringe to use when you have to inject, for example, 1 ml or 1.5. It is divided into a zero point 0.5, which you can use, or back to this one, you can use the 1 ml. Very good all purpose. Then this one, the 10 ml, you may use this. This is a good utility syringe for many other things to draw samples, for example. But probably unlikely unless you have to give perhaps 3 or 4 mLs, which is a whopper of a dosage. And you have to give that, right? 10 ml. I am going to note that all of these, as you can see on the package, is the term here is lure lock. That's so your syringe, your needle can lock down. That's the special tip on these. All preparations can use this for sub-Q, intramuscular, and perhaps intermuscular for other purposes of the syringe. The next type of syringes that we're going to be looking at, two specialized syringes of note. First is that you cannot choose the needle as the nurse in these cases. Okay? You can't remove them. So an insulin injection or TB injection, not use the blunt system of a pre-drawing needle. Just use this needle to both withdraw the medication and inject the medication. Insulin syringe. Critical designation of this is it is divided into what? Units, not tenths of a milliliter, but units. Very specialized. It's the only syringe that you can use to inject insulin. You can never use a traditional syringe to inject insulin. Marked on the package, after orange, it's designated on the barrel of the syringe. But most importantly, your nurse check is that it's divided into units. Again, I know I'm repeating myself. This syringe is the TB syringe. Very small, gauge needle, 1 inch in length, but you will never, ever with an intradermal inject a full inch. We'll be talking about that later with intradermal injection. Okay? Divided into tenths of a milliliter. Those are two, your two, obviously, your two types of specialty syringes. First, let's go to the intramuscular. Today, what we're going to be giving first as our demonstration medication is influenza. That's the way it will read on the physician's note as influenza vaccine dosed as 0.5 milliliters. The vaccine dosage itself is set. 0.5 is always the influenza amount or the dose of it in this particular case. I clearly read the expiration date and we are fine. All right. Intramuscular, what I had promised you. Rubber home, 30, to the count of 30. Okay, we'll do that. And there we have it. Today, what I'm going to be doing, I have picked a 0.5, which I can use on my 3 ml. I'm doing this so that you can visualize it a little bit better. What's another choice of a syringe that I can use? The 1 ml, again with the lure lock tip, the 1 ml. Actually, I'm going to change my mind. I will demonstrate this because a 0.5 is very easy to draw. Half the syringe is very easy to draw on this one and see. What did we talk about before with the intramuscular only? Here's my red blunt. Once again, repeating myself, never ever to utilize. I apologize. One moment. Lure lock. Locked in to the blunt. In preparation for injection into the vial of medication, is we draw my dosage amount, 0.5 in this case, of air. We draw air into this. Show you in a moment why. I already scrubbed my vial. I am barehanded. Uncap vial for nurse safety that I had promised you. For nurse safety, vial down, inject. Up, two-handed, obviously to keep the needle in. Right? Inject the air. The reason we're doing that is if we had many nurses come in and draw zero point 0.5 mLs, they would create a vacuum within the vial. Therefore, we're putting a little air in to prevent the vacuum and to enable the medication virtually to pump out. Once I had pushed the air in, now I draw to my zero point 0.5, holding it in my hand, both zero point 0.5 halfway down the syringe. Now I have my syringe filled with fluid, with the medication. Real world nursing, guaranteed this will find you, and that is bubbles in the syringe. You may have seen many times nurses doing this to get the bubbles out, holding both together like this. Okay, holding both of these together, I snap, snap directly at the bubble, and it may go up all the way to the top, and then just a tiny amount push the bubble away, injecting medication back in to the vial. That's why we hold both together. Ready? Now, it doesn't work. Real world nursing won't work all the time. Technique: pump it back up, redraw to your dosage slowly. This may relieve the bubble, right? Third technique: back up, push your medication back in, and draw a little bit, perhaps a significant amount, more than the med amount that you need. Gives you more fluid to work with. Snap, snap, oops, snap on the barrel, and it may relieve. Critical with this method, obviously, what did I do? I pulled beyond my dosage. I have to go back to my dosage. You follow me? I want to make another point, which I didn't before, is when I'm working with the vials, they are down on your bedroom table. I'm going to reverse myself and just show you. I honestly had scrubbed my hub down, inject. Not this to begin my needle. Wow. Right in my hand. Ooh, poke. So we don't do this. We put it down, inject, do everything that I just described to draw my med, withdraw. Nurse safety, we don't recap like this. Poke your hand again. We scoop. We scoop our needle. Ready? Today, I've chosen my 23 gauge 1 inch, my favorite personal intramuscular all purpose needle. Blue is the hub color. Remove my blunt as I described. Replace with my 23 gauge. Ready? You're ready now to go and inject. What did I say earlier in the lecture? I'm going to go touch the patient now. Now I'm ready. Today, as I mentioned earlier in our session, this will be my deltoid muscle. I've identified my site right in the middle of the deltoid. Now, obviously, it's not up on my shoulder. I have to demonstrate down. Think for one moment, what is the distinction about an intramuscular injection? The Z tract or intramuscular only. What is the Z tract? We pull the skin aside to move the dermal layer and the subcutaneous aside for a moment. Then, process wise, I will do my injection. Right? Inject slowly. I demonstrated too quickly. Inject slowly. We will be withdrawing the needle and release the Z. That's called, again, the Z. When we do that, that's the proper way to administer an IM. Always do that gently, pull the skin aside. A needle is obviously charged with my medication. Rub the skin. I do it at the count of 30. 10, 15, 20, 25, 30. Now, of note that I want you to see is the injection speed. The injection speed here. We don't go slowly. We dart it in. We hold it as a dart all the way down near the hub. We pull our cap off, obviously. Retract. Now speed. About 1 to 1.5 inches above the skin surface, not up here and going like this. Boom. We're down about 1 to 1.5 inches above, and crisp and confident, dart it in. Crisp. Quick. Get it in there. It also plunges it deep into the muscle. We never leave metal needle exposed. We go right to the hub. You don't see that? Withdraw, release the Z. Now, in the plunging of the medication, Z plunge, we go slowly. The designation is 1 ml, count to 10. Today we had what? 0.5, we count to 5, right? Per tenth of an ml over those amount of seconds. We don't go boom. Withdraw, release the Z. And again, what I don't have on my traditional old needle is a safety guard. You will flick your safety guard and both go into the sharks together. Have you ever had the chance or whatever to recap for some reason the scoop? I spend extra time on the intramuscular because now as we do the sub-Q and the intradermal, the drawing process of the medication is the same. So, subcutaneous. Site choice. We need what to work with? Subcutaneous tissue. All right. What's the most common? Perhaps the abdomen. Of note, we don't inject repeatedly on the same general area of the abdomen, do we? We do what? I know you know this. You create quadrants. Mentally, obviously, in your mind, I divide it into four quadrants. Breakfast of insulin, perhaps, for example, here, it's designated in the notes, right upper quadrant. Lunch, I have to inject coverage for regular insulin, here, and so forth. You would rotate your sites. Of nursing note, we never inject, obviously, into the umbilicus, and we stay outside 2 inches from the umbilicus. So your injections are out here. Of other sites, the fronts of the thighs into the sub-Q. The needles are tiny short, so they won't penetrate into the muscles for subcutaneous needles and injection. The other site of note is the fatty tissue on the back of the arm. Also, a common site and a good site for nurses to use when a patient is receiving multiple injections on the abdomen. Good site, easy access. Sub-Q. Today, we're going to be giving regular insulin as our subcutaneous demo. Nurse check. Am I giving regular? And once I draw, do I have the proper dosage? Right? You know, obviously, what is step one for an insulin injection is the test of the blood glucose via the glucometer. Before I would inject insulin, of note, real world nursing, what do? I have that tray in the room, the breakfast tray, lunch, the meal tray, etc. It's in the room so that we don't wind up with somebody going hypoglycemic on us if they have to, if that occurs, rather, I should say. Right. We discussed the insulin syringe. You can't see it very easily, but it's designated in, once again, what? Units. I will be injecting today. I don't have one, and I don't have that needle situation where it's selected for me. I just want you to envision that this is my insulin syringe. I spent the extra time, as I was describing, to go slowly through the intramuscular preparation through. Obviously, we scrub the hub. What do we do? Vial is down. Pre-draw the air, which honestly will be tiny in an insulin amount of units, very small ordinarily, but still draw your air. Vial down, inject. What was it before, folks? Up, draw the tiny amount of it, handle bubbles, just the way we talked about. Withdraw, hand to a nurse check for a second check, and here we go. Then angles of subcutaneous injection. The range of the angle is 45 to 90. Now, most patients that you will see, and the nurse can do with the pre-prepped needle, which is less than 5/8 of an inch, you can go 90. In somebody who is very thin a child and or a child that does not have a lot of subcutaneous tissue, we go in at a 45-degree angle. With adequate subcutaneous tissue, we do not have to do what you may have heard is the pinch. Now, proper evidence based is that you don't need to do the pinch with adequate sub-Q. Right? Rub my site to the count of 30. This particular case, 90 degrees, and push it in and inject. Notice I'm securing it this way. What don't I do? Remember, back to the IM, no Z track. This is sub-Q. And withdraw. Now, you may see and you may hear it is not on the rubric, but evidence-based practice is that once you inject, you hold the count of 5. Rationale to allow for the medication to disseminate into the sub-Q before withdrawing the needle. Talk to your professors about this, please, with the injection procedure. Like I said, this is not included on your rubric. You have completed the sub-Q injection. Lastly is our what? Our intradermal. What do we administrate intradermally only? Is something that we all have received is our tuberculin test. Tuberculin test is not the thing that is written in the EMR. The EMR will read PPD. What is that? If you see on the label, it doesn't say, it says purified protein derivative. If you can see it, I know it's hard to read. Once again, expiration date. In our particular case, and with most companies or hospital protocols that you need, the manufacturer is also documented along with the expiration date. That's distinctive to the ID injection. Right. Now, dosing 0.1 ml per intradermal injection. That is the standard for PPD injection intradermally, 0.1. So, what syringe would I pick? Now, if you remember way back to our needle theory, this is normally selected for you. Now, in this case, this is what it looks like. It's a 1 ml syringe divided into tenths of an ml. I'll show it to you here. In this particular case, it has a lure lock on it. Ordinarily, with TB syringes, their tips, because the needle is chosen, will look like this, a standard, what they call a straight tip. You don't need a lure lock because you're not choosing the needle. There will be my syringe as a demo. Where do we get this? You all know this, the location. What is it? the inner aspect of the forearm, isn't it? About midway. Now this is an arm. What do we do first? Purified protein. Everybody remembers this now. Alrighty. For our hub. What do we do first? You can leave your cap on. Draw air to the zero point 0.1. Very small dosage, isn't it? I scrubbed. I would what? Inject. Same principles that we used before. Inject my air, withdraw to zero point 0.1, invert when I'm preparing for my needle, you go back into the room, or in most cases, a doctor's office or an industrial, hospital included, clinic, industrial nurse that you're going to be working with in the office. Prepare. If you have to, what do we do? Poop to walk to the patient. Right? Our prep, rub the skin for circular motion down to 30. You know what I mean, 30. Right? Secure the arm. Now, distinction here is that we cannot inject in a dart fashion, can we? Because our angle of injection would have to be too steep. Today, in this, we hold the syringe like this, right? And we will be coming in at around, if you can see that, an angle of about 10 to 15 degrees. Bevel of the needle, that's the angle tip to make it sharp. The bevel of the needle is up, not down. Set your needle and inject just under the skin. Very tiny amount, less than 1/8 of an inch. Take a look at a ruler, a traditional ruler, and see what 1/8 of an inch looks like. It's tiny. But even so, visually, just under the skin. Then, what will we do? Inject very slowly, even though it's 0.1 ml. Slowly. We all know what happens, don't we? It creates a raised area of the skin in a circular pattern called the wheal. WHWAEAL creates a wheel. Withdraw your your sub ID needle. Now it's in a circular pattern. The key here is our nursing actions. It must be read 48 hours to 72 hours, not before, not after. If you do go after, you will have to repeat it after 72 hours. Now, if it's positive, do we all know what the positive is? You will see the industrial nurse or the nurse aide, whoever is administering the medications for you, they will see if there are any raised areas, redness, or our term is induration, 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 which means firmness or hardness. underneath the skin. You can feel it. Some nurses have described it as almost as if there's a little disc of firmness underneath the top layer of the skin, induration. These are indications of it being positive. You would then need a follow up chest x ray. All of this is not obvious if you receive the blood test, the gold standard blood test. Ready? And that is intradermal injection. So, today in our workshop, good to see you back again. Today in our workshop, we reviewed what? All of the safety points and the intramuscular, the subcu, and the intradermal. That concludes our in-service for today. And thank you all. If you have any questions, you can review with your prof or again, email me questions and I am Mark Thiel, Thiel. Okay, thank you very much, everyone. Take care.